Mr. Chairman, dear colleagues, the aim of this presentation is to show you 3 years corneal cross-linking results in pediatric patients with progressive keratoconus. So as we all know, the progression of keratoconus in the pediatric age is very dramatic. And here there is an example of a patient of 12 years old who came to our attention, and we told him to come back in 4 months. And in 4 months we saw that the progression of the cone was so high that he lost more than 150 microns. So in this case, we couldn't do cross-linking anymore because the thickness of the cornea was around 300 microns. The patient couldn't fit contact lens, so we had to do a PK. As we all know, PK complications in pediatric patients are higher than adult patients. And the reason why we started doing cross-linking in pediatric age is that we couldn't see any dramatic complication in all the patients, adult patients that we've been treating since 2006. Most of all, we didn't see any reduction in endothelial cell count. That's why I started treating these patients, and the number of eyes of the study is 66 eyes, stage 2 keratoconus. The average age is 15 years old, and we treated from 9 to 18 years old. There were more male than female, and in all these patients we saw a progression, and the progression was documented by serial differential topographies and pachymetries. The treatment was a standard treatment with the removal of the epithelium, and we use Ritrolin and the CBM-CSO Vega machine to treat the patient. So what about the results? We couldn't see any statistical significant difference in the endothelial cell count at 1 year, 2 years, and 3 years after cross-linking procedure. There was a significant increase in uncorrected and best spectacle corrected visual acuity from the first year after cross-linking to the 3rd year after cross-linking. And if we compare this population with the adult population, we could see that there was a higher increase in best spectacle corrected visual acuity in the pediatric population than in the other patient in the first years after cross-linking. Cross-linking appears to be a safe procedure. We couldn't see any loss of best spectacle corrected visual acuity. The only patient who came after 3 months and 6 months to our attention with a reduction of best spectacle corrected visual acuity had some conjunctivitis and blepharitis and some photophobia. What about the correction, the sphere and the cylinder? Was statistically significantly low in this population, but we could see an increase in the astigmatic correction. The sphere variation was more or less the same that we saw even in the adult population. And for the cylinder variation, there was a higher increase in cylinder in this population if compared to the adult population. The stability of the spherical equivalent over time is shown in this slide, and as you can see, at 3 years after cross-linking, the spherical equivalent remains pretty stable in all these patients. Why do these patients have an increase in best spectacle and uncorrected visual acuity? Because there was a significant coma reduction. What about the pentacam and the results related with pachymetry? If compared with the adult population, pediatric patients recover their thickness faster than the adult eyes. In the adult eyes, we couldn't see any statistical significant difference if compared with the previous data after 2 years from cross-linking. In pediatric patients, the recovery of the thickness was at 1 year after cross-linking. The Ambrosio indices didn't show any statistical significant difference at all after 2 years, but there was an increase in for the topography result with statistical significant difference in CMK with a reduction of the keratometric indices in all these patients. The class indices didn't show any significant difference in the pediatric population if compared with the adult population. And what about the maps? This is a map of a child, and in the upper part of this slide you can see the topography of the patient before cross-linking, and below the topography of the patient after cross-linking. And as you can see, a keratoconus map after cross-linking resembles an irregular astigmatism, and this can be a reason why there was an increase in astigmatic correction after cross-linking, with a comma reduction and an increase in best spectacle corrected visual acuity, and the spherical equivalent with an increase in astigmatism if compared with the sphere. This is another example with a differential instantaneous map which shows a reduction of more than 5 diopters after cross-linking. The results are at 1 year in this case. And this another example with a reduction of the true net power in this keratoconic patient 1 year after cross-linking. And here is another example with a dramatic reduction of the steepness of the cone in the inferior part of the cornea. So cross-linking is indicated in pediatric population with progressive keratoconus, appears to be effective in improving uncorrected and best spectacle corrected visual acuity by reducing corneal asymmetry and corneal wavefront aberration at 3 years follow-up, is a safe procedure with faster reepithelialization and faster recovery of CCT in the pediatric patient, but most of all a careful screening and a closer follow-up is needed in pediatric age to avoid faster and more dramatic progression of the disease. Thank you.